All right, our topic that we will go into now is abnormal vaginal bleeding. Actually, we're going to look at the next three topics are abnormal bleeding, primary amenorrhea, secondary amenorrhea. And what I want to point out is that in all three of these, we have anatomic etiologies and we have hormonal etiologies. So as we go through this, it may help for you just to, in your brain, organize these anatomic and hormonal. And we have our case. A 31-year-old patient visits the office complaining of 6 months of menometrorrhagia. Now that's a long word, isn't it? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 letters. Now there are not many English words that have that many letters. Now Germans, they have a lot of letters in their words. But when you have an English word which has this many letters, you know what it usually means? We don't know what we're talking about. So let's see, menometrorrhagia, what is that? Heavy, unpredictable bleeding. Not predictable in amount, duration, or in time. The patient states menarche was at age 13. How's that sound? Is that about average? Yeah, that's about average. She's had regular menses until the past 6 months. Pelvic exam, including a pap smear, is normal. So, menometrorrhagia. This is a table from my board review series book that I made, and it looks at the various kinds of terms that we use. We're looking here at menstrual cycles. The heavy lines, vertical lines, are the monthly, and the light vertical lines are weeks. So we have week 1, 2, 3, 4, 1, 2, 3, 4. With a normal menstrual cycles, you can see there's about 5 days of bleeding, which occurs every 4 weeks, which is predictable and which is regular. Menorrhagia is where you have predictable in terms of every 4 weeks, but it varies in terms of duration and the amount. Hypomenorrhea is where you have predictable cycles every 4 weeks, minimal flow. This patient probably doesn't complain. Polymenorrhea is where you have bleeding which occurs regular and predictably, but notice it is less than 3 weeks apart. Oligomenorrhea is where you have predictable menstrual bleeding, and it occurs more than 5 weeks apart. Metrorrhagia is where you have every 4 weeks there is bleeding. You notice that? Every 4 weeks, and is predictable in duration and amount. But in between, there is irregular, unpredictable bleeding. So we have normal cycles, in between which is irregular bleeding. And that's going to be an important distinction as we go through. The menometrorrhagia, there is no predictability of any kind in terms of frequency, in terms of duration, in terms of amount. What do you think? You like that? Did I do a good job with this? Thank you. I appreciate that. Actually, it doesn't tell you anything. It doesn't give us the etiologies. So let's see if we can figure out what the etiologies are. Basically, the abnormal bleeding can be from pregnancy, anovulation, anatomic lesion, hyperplasia, and we will go through this once we have gone through the chapter. Firstly, rule out lower genital tract lesions with a speculum exam, and you can do that very simply in the office. Is there a cervical lesion? Is there a vaginal lesion? If there is no lower genital, then we need to rule out a pregnancy complication. And how do you do that? Very simple, a beta HCG. If the beta HCG is negative, you can assume that there is no functional trophoblastic villi. If she is not pregnant, the most likely cause is anovulation. This has sometimes been called dysfunctional uterine bleeding, or DUB. This really refers to a bleeding where there is no anatomic lesion. Most commonly, it is hormonally related. In the case of anovulation, the problem is we've got decreased or absent progesterone. The uterine lesion would be an anatomic lesion, either a submucous leiomyoma or a polyp, and we need to then image the endometrial cavity. What is abnormal menses? You can see here, this is a histogram of a large number of women and the length of their menstrual cycles. You can see that the mean, the mode, the median is 28. But when you compare what is under the red rectangle, what is outside of it, you can see that most women do not have 28-day cycles. They can be fewer days or they can be more days. And you can see if we say 28 minus 7, 28 plus 7 will include the most of these women. So how about if we say abnormal bleeding is bleeding that occurs less than 21 days apart, which occurs over 35 days apart, or is unpredictable and irregular. Now there is actually one more which is used in studies, which I think is not really helpful in terms of clinical work, and that is the amount of menstrual flow is more than 80 milliliters. Now, a patient comes in and says, I have heavy periods, and you say, how many milliliters? Well, I don't think that's really clinically helpful at all. So let's use these three. Less than 21 days apart, over 35, unpredictable or irregular. Now, once we've ruled out a lower genital tract lesion, then always rule out in reproductive years pregnancy. And we've already talked about the causes of first trimestral bleeding, threatened abortion, inevitable abortion, missed abortion, all those kinds of things. Beta HCG, if it's negative, we'll rule that out. If the beta HCG is positive, sonogram will tell you what's in the uterus, and we don't need to look through this again. Individualize. An anatomic lesion typically has a history, and this is important to remember for the exam, if there is unpredictable bleeding between normal menses. There is normal menses every 4 weeks, but there is bleeding which occurs unpredictably between. It could be a vaginal lesion, it could be a cervical lesion, it could be an endometrial lesion. You remember when we talked about cervical cancer? The case was a woman who had normal menses, but who has postcoital bleeding in between, and that was a cervical lesion. So a pelvic exam, speculum exam, will give you lower genital tract etiologies. I will show you what a saline sonogram looks like. I'll show you what hysteroscopy looks like, and we'll talk about endometrial biopsy. This would be anatomic lesion. But probably if she's not pregnant, the most common is dysfunctional uterine bleeding, which is most likely anovulation. The history is typically irregular, unpredictable bleeding with no orderliness whatsoever. We already talked about this when we looked at the overview of menstrual physiology. If you have unopposed estrogen, you have a hyperproliferative endometrium, which starts shedding off irregularly, unpredictably. There's no spiral arteriolar spasm. There's no limitation because of the irregular sites of the shedding. This is as distinct from the progesterone withdrawal bleed, which is limited in amount. There is no cramping. Why there's no cramping? Because there's no spiral arteriolar spasm, there's no progesterone withdrawal, there's no prostaglandin release. The cervical mucus, what will it look like? At the time of menses, if you've got progesterone withdrawal, you will have thick and sticky. This is clear, watery cervical mucus, and that will give you a hint. If you did a basal body temperature, it will be monophasic. There will be no mid-cycle rise because there's no progesterone, which stimulates the temperature control center of the brainstem to raise the basal body temperature. How do we treat this? We want to stabilize the endometrium. We stabilize this using medroxyprogesterone acetate. This is the generic name. Trade name often is Provera. And remember, progesterone stabilizes endometrium. Now, this patient does not need estrogen. She's got estrogen, but often, just for convenience sake, physicians will often use combination oral contraceptive pills, which has estrogen plus progestin, but really all she needs is progestin. If she is anovulatory, there are correctable causes of anovulation, which are hypothyroidism, get a TSH, hyperprolactinemia, and angiopituitary prolactinoma. So get a TSH, prolactin. If they're both normal, then we'll assume it is idiopathic, and we will just cycle her with either monthly MPA or combination oral contraceptive pills. Remember, if we have unopposed estrogen without progesterone, it can go from simple hyperplasia to complex hyperplasia with atypia, and even endometrial carcinoma. And that's what we want to prevent. The most common synthetic progestin which is used is Provera, or medroxyprogesterone acetate. Progestogen is really a synonym for progestin, and I don't know if there's any difference between the two, but they're synthetic progestins. On the exam, they will not use trade names. They will use the generic, which is medroxyprogesterone acetate, or MPA. What if there is no anatomic lesion, there is no pregnancy, you give hormones and it doesn't work? In the olden days, a hysterectomy would be performed for failed hormonal therapy. Now what can be done is what is called global endometrial ablation. This is where you basically destroy the endometrium, cause scar tissue, iatrogenic Asherman syndrome, and when you've got scar tissue, you won't have bleeding. Prerequisites: failed progestin therapy, normal menstrual cycles, normal endometrial biopsy, no uterine anomaly, pre-treatment GnRH agonist to give a low estrogen and a atrophy of the endometrium. Then you can either use a thermal balloon, cryotherapy, or a microwave. Let me show you what that looks like. This is the balloon which you put into the endometrial cavity. You fill it with a fluid. Within the balloon is a heating element. The heating element makes this fluid so hot it scorches the endometrium and causes scar tissue. And scar tissue will not bleed. So you can preserve the patient from a major surgery, although obviously this is not for a woman who wants to maintain reproductive function. NovaSure is one of the devices which is used for this. If progestin treatment fails, endometrial ablation. You can also use a microwave device like this. This is a wand. The microwaves penetrate 3 millimeters. You put it into the endometrial cavity, and then you can see this is the lining of the endometrium in gray. And what it does, it basically just destroys it. And when you have no endometrial lining which is left, the bleeding should stop. This is an endometrial biopsy, which is done blind by putting a curette into the endometrium and then withdrawing some of the endometrial lining. This is a saline sonogram, hysterosonography sometimes it's called. You put a catheter into the endometrial cavity, you inject 5 to 10 cc's of saline, you have an endovaginal probe, and the saline pushes apart the walls of the endometrium. And you can see here, it highlights these lesions, polyps, which are in the endometrial cavity. This is the ultrasound endovaginal probe, and here is the catheter. This is the bladder right here. You can see on this ultrasound the endometrial thickness. You can see here is the saline in the endometrial cavity, and you can see there are no lesions there. This is the myometrium. This is the myometrium over here. Now compare this ultrasound image to the next one. And you can see very clearly we've got something here. Now, I don't know what it is. It looks like it could be a submucous leiomyoma. It could be a polyp. And this will have to be removed hysteroscopically. Here is a polyp, which is labeled P. Now, you would not see this normally until you put the saline, which surrounds it, and which then gives you a fluid tissue interface. This is a hysteroscopic view of the endometrial cavity, and here we have a large polyp. This, you should know, this was produced by tamoxifen. Tamoxifen is a selective estrogen receptor modulator, SERM. It has estrogen agonist effects in some tissues, estrogen antagonist in other tissues. Tamoxifen has an estrogen antagonist effect on the breast and is used for either prevention or treatment of breast cancer, but it has an estrogen agonist effect on the endometrium and has produced this large endometrial polyp. So women who are on tamoxifen need to be monitored for endometrial hyperplasia and even cancer. This is endometrial cancer seen through a hysteroscope. This is a submucous leiomyoma, and you can see how clear the margins are all the way around. This is a characteristic of a benign lesion. Notice on the endometrial cancer, there is no clear demarcation between the normal and abnormal tissue. This is endometrial atrophy, and some of the reasons for postmenopausal bleeding can be endometrial atrophy. You can see how white, how atrophied this endometrium is, but here we have an area of hemorrhage. This is the tubal ostia on either side. This is a board question. Is estrogen ever given to women with dysfunctional uterine bleeding? Now, the problem which causes dysfunctional uterine bleeding is estrogen. So why would you want to give estrogen? This is an unusual situation where you have an adolescent within 2 years of menarche. Now remember, it takes 2 years from the onset of the first menstrual period until you have regular ovulatory cycles. During that period of time, she can have a prolonged period of unopposed estrogen that stimulates the endometrium to where it starts hemorrhaging and bleeding, to where it even sloughs off all the way down to the basalis layer. And now you have blood vessels which are involved and which are bleeding. By giving high doses of estrogen, IV, for 24 to 48 hours, you can stimulate rapid proliferation of the endometrium, stop the bleeding without having to do a D&C. So this would be sometimes called a medical curettage. All right, let's review what we said. Abnormal vaginal bleeding can be from anatomic lesions or from hormonal causes. Anatomic could be a pregnancy complication. We ruled that out with the beta-HCG. Or you could have an anatomic lesion of the vagina, the cervix, the endometrium, and we talked about that. Hormonal causes could be anovulation. This is often the main cause for dysfunctional uterine bleeding. You have an unstable endometrium, which is estrogen dominant. Or you could have endometrial hyperplasia, where you have such proliferation that now you've got abnormalities which need to be treated. Pregnancy is probably the most common cause of abnormal bleeding in the reproductive years. Get a beta-HCG. An anatomic lesion is characterized by regular menses with bleeding in between the regular menses. If the history is irregular menses with unpredictable bleeding, that's when you think more likely of anovulation or dysfunctional uterine bleeding. Endometrial hyperplasia would be less common, but certainly should be considered. The risk factors for this would be obesity, hypertension, diabetes, and let's add a fourth, age over 35. All right, let's summarize what we've said. The most common cause of abnormal bleeding in the reproductive years is pregnancy complication. Rule this out, do a beta-HCG. And then the management will be as per whatever you find. If she is not pregnant, the most likely cause is a hormonal problem. The most common hormone which is missing is progesterone, no progesterone. The history will be one of unpredictable bleeding in terms of time, duration, amount. Management, give a progestin trial, medroxyprogesterone acetate for 7 to 10 days. What should happen? There should be cessation of bleeding. The bleeding should normalize. After you stop the progestin, she should have a normal withdrawal bleed. If she does, that confirms you've got anovulation. The management is check out and make sure she doesn't have a correctable cause, which is hypothyroidism, get a TSH, or a prolactin-producing tumor, get a prolactin. If these are normal, we will just cycle her with progestin every 1 to 2 months. Okay, if it's not anovulation, you must think an anatomic lesion. We talked about how you can assess that. The history is typically bleeding between normal periods. And here we've got a speculum exam, we've got the hysteroscopy, we've got the saline sonogram. If there is a upper genital tract lesion in the uterus, hysteroscopic resection. Okay, hyperplasia. Who should you do an endometrial biopsy on? Obesity, hypertension, diabetes, and age over 35. If you get hyperplasia without atypia, this typically will respond to medical treatment, progestin, medroxyprogesterone acetate for 7 to 10 days, and then repeat the biopsy in 3 months, and we cycle her every month. If she has hyperplasia with atypia, that is more concerning because that could very easily turn into endometrial cancer. If she was not a surgical candidate, let's say she had chronic obstructive pulmonary disease, she had coronary artery disease, diabetes, you could try medroxyprogesterone acetate too. But my recommendation would be total abdominal hysterectomy or total vaginal hysterectomy. All right, and that is the end of abnormal vaginal bleeding.